Welcome to Dr. CM Edcast, your go-to resource for medical learning. Through discussions, case studies, tutorials, and debates, we help you learn, grow, serve.
So, picture this. A patient presents with severe bacterial diarrhea. Choosing the right antibiotic is absolutely critical. But how do you navigate all the options? Well, today, we're going to break down the pharmacology of antibiotics for these enteric infections. And this isn't just about what you'll do in clinical practice. It's about mastering a super high-yield topic for your exams in a way that's actually going to stick. Here's our game plan. First, we'll get a handle on the clinical problem itself. Then, we're going to zoom in on a prototype drug class, the fluoroquinolones, to really see how they work and where we use them. After we cover their risks, we'll zoom back out to compare them to other antibiotics, and finally, we'll lock in the most important exam takeaways. Sound good? Let's get started. Okay, so to really understand the solution, you have to appreciate the problem first. And let's set the stage with a classic and, frankly, a pretty terrifying example of a bacterial enteric infection, cholera. When you hear the phrase rice water stools, this is exactly what should come to mind. And let's be clear, this is not just simple diarrhea. We're talking about a massive, incredibly rapid loss of fluid that can send a patient into hypovolemic shock and even cause death in just a matter of hours. That's why the very first thing you do is so critical. And this brings us to what is probably the single most important point of this entire talk. Before you even think about reaching for an antibiotic, the first most life-saving intervention is rehydration. Those packets of oral rehydration salts, or ORS, are often enough. The antibiotics, they treat the bug for sure, but it's the fluid replacement that keeps the patient alive. All right, with rehydration well underway, we can finally turn to the pharmacological treatment. Now, a really smart way to learn pharmacology is by using what we call a prototype drug to understand an entire class. And for many of these bacterial diarrheas, our go-to prototype class is going to be the fluoroquinolones. Our prototype drug is ciprofloxacin. And the reason we do this is simple. It's efficient. Ciprofloxacin's mechanism, its uses, and its side effects are basically the blueprint for the entire fluoroquinolone family. If you master ciprofloxacin, you can handle exam questions on ofloxacin, levofloxacin, and the rest. It's just a much smarter way to study. So let's get into the nitty-gritty. How do these drugs actually work at the molecular level? And what are their primary targets when we're talking about enteric infections? The mechanism here is actually incredibly precise. Fluoroquinolones go after two very specific bacterial enzymes, DNA gyrase and topoisomerase 4. You can think of these as the little machines that unwind and then separate the bacterial DNA so it can be copied. By blocking them, these drugs essentially just jam the bacteria's copying machine, completely stopping it from multiplying. Now, the consequence of this mechanism is key. Stopping DNA replication is so catastrophic for the bacterium that the effect is bactericidal, meaning the drug actively kills the bacteria. This is a really important distinction from a bacteriostatic effect, which just kind of stops them from growing. This is much more aggressive. Okay, so with that powerful bactericidal activity, how does this translate into clinical use? Well, it makes them effective against a whole range of nasty gut pathogens. The list here is pretty extensive, right? It covers major culprits from Salmonella typhi, which causes typhoid fever, all the way to Shigella and some of the more problematic strains of E. coli. Of course, no drug this effective comes without some risks. Understanding the adverse effects and, just as importantly, who should not receive these drugs is just as critical as knowing what they treat. The common side effects are kind of what you might expect. Some GI upset, maybe some CNS effects like a headache or dizziness. But the one you absolutely positively have to remember for your exams is the risk of connective tissue damage. Specifically, you need to burn this into your brain. Fluoroquinolones are associated with tendinitis and, in the worst cases, actual tendon rupture. The classic example is the Achilles tendon. So, because of that risk of damage to connective tissue and cartilage, the rule is pretty straightforward. Fluoroquinolones are generally a no-go in pregnancy, during lactation, and in any kids or adolescents under 18. This is one of those hard and fast rules you just need to know. Except when it's not. And this right here is a classic exam pearl. They love to test this. There are a few very specific, very severe infections where the benefit of using the drug is considered to outweigh that potential risk. And the textbook example is using ciprofloxacin to treat typhoid fever in a child. They'll test you on the rule, but you can bet they're just as likely to test you on this specific exception. Okay, so we've gone deep on our prototype. Now let's pull back and zoom out to compare the fluoroquinolones to the other major antibiotic classes we use for enteric infections. This is where you learn to make the right clinical choice. This table is really a fantastic way to differentiate these classes. Just look at the different mechanisms. You've got tetracyclines and macrolides, which are bacteriostatic protein synthesis inhibitors. Then you have metronidazole and cotrimoxazole, which are bactericidal, but through totally different pathways. And each one has a classic indication, like doxycycline for cholera or metronidazole for C. diff, and a key adverse effect you have to remember, like the staining of teeth with tetracyclines or that disulfiram-like reaction with metronidazole if the patient drinks alcohol. All right, we have covered a ton of ground. Let's pull it all together now and really consolidate the absolute must-know points, both for your clinical practice and, of course, for your exams. This is your rapid review, your mental flashcard. If you walk away remembering just a few things, make it these. Cholera means rehydrate first, then doxycycline. Typhoid fever, you think fluoroquinolones. C. diff, you think metronidazole. And never, ever forget the major contraindications and those red flag adverse effects for tetracyclines and fluoroquinolones. So let's put it all together into a simple 3-step clinical approach. Step 1, always, is to assess and aggressively treat dehydration. That's the most immediate threat to life. Step 2 is to use your clinical clues to figure out the likely pathogen. And finally, step 3 is to choose the right antibiotic based on that likely bug, your specific patient, and local resistance patterns. And that brings us to our final thought. The guidelines we've just discussed are all based on current sensitivity patterns. But we all know that bacteria are constantly evolving, constantly developing resistance. And this leaves us with a really critical question for the future of medicine. As our first-line drugs start to become less effective, how are we going to need to adapt our approach to treating these very common but still potentially deadly infections? It's something we'll all have to face.